will begin this morning with Dr. Stuart Brown with the State Health Director.
Thank
and we're
you.
so glad that he can join us today, and he's sitting amongst us and not quarantined on the side. He was sick last week. But
I can tell you I feel a whole lot
Good,
better.
we're so
Thank you. I'm so pleased to be here. I just wanted to really make sure that we are thinking about the way that we're investing dollars almost as a business model and try to think about it as a investment strategy. We know that the state of Georgia has not very good health. We rank 42nd nationally. And out of a broad consensus group in November of last year at the summit, we had a boiling down of what are the issues that contribute to this into 7 major areas. The problem with access to health care, the lack of insurance, poverty scattered throughout the state, educational attainment, which is a strong predictor of health, and whether or not our communities are safe and whether they support healthy behaviors. And then the overriding problem of disparities that our state faces all the time, everywhere, whether we're talking about disparities by race, whether we're talking about disparities by gender, whether we're talking about rural-urban disparities. So they abound, and they really need to be a part of the way we're thinking. The priorities that we have identified, and I believe I've shared these previously, are those that the statewide public health leadership believes are most likely to be the places for investment that would improve health. And those are investments in safety, investments in health behaviors, and investments around birth outcomes. The public health functions that I really just wanted to just very quickly do a reminder on. We primarily assure clinical services by either referring people to clinical services or when clinical services are not available for referral, doing those ourselves. But I want to underscore that we do not believe this is the best long-term strategy for Georgia's health. That we believe that people need a medical home that provides the gamut of health care. We tend to provide very categorical, specific clinical services. And so we think it's an essential part of our function to try to build that care capacity at each and every local area where it does not exist. The other things that we must do in order to help the community is to really monitor what's the health of that and to identify the problems so that the community can help set priorities. And then from those can develop those partnerships that are going to be crucial. And as you heard, Madam Chair, at the summit, that the problems are so multifaceted and broad that public health alone is not going to be able to address the health issues. We're going to have to depend on partners. And then we're going to have to use this infrastructure of data to monitor what's been successful in the work that we do. And finally, we need to respond to emergencies, whether those are catastrophic emergencies, outbreaks, or local environmental threats. And then out of this comes the occasional need to promulgate, more than occasional, I should say, to promulgate policies to support those. So the challenges that we face in public health are that federal and state funds are declining, and people will go into that in a bit. The Medicaid changes have caused substantial shift in our core funding base, and we face new public health issues. Preparedness never was a part of what people used to talk about for public health. Chronic diseases are growing and consuming such a portion of our healthcare dollars that it means that we've got to get upstream on the underlying issues around chronic diseases and address issues around tobacco use and obesity and a variety of other chronic conditions. And finally, we need to really be clear that some of our very effective clinical service programs reach only a tiny portion of the population that they're intended to serve. So, for example, SHAP covers about 5%, we estimate, of the population that's in need for those services. Cancer screening covers maybe 15% of the population that's in need. And the Cancer State Aid Program covers approximately 5% of the population that is in need. So there are challenges that don't have really to do so much with the total dollars, but they have to do with what is it we're doing with those dollars and how do we do a more focused piece of work. Thank you very much.
Thank you, Dr. Brown. Any questions? Thank you. Now we'll hear from Amy Hughes.
Dr. Brown, which is the button to forward the slides?
Pressing down.
Okay.
Down arrow.
Good morning, Madam Chair and gentlemen. I'm going to do a brief overview of the statutory mandates for the local public health board, the county boards of health. The principal statutes that deal with county boards of health are found in Chapter 3 of Title 31. However, many other mandated duties are found scattered throughout the code. And that's very well illustrated in the duties of the environmental health sections of the county boards of health. The regulation of on-site sewage management systems, which is septic tanks, is found in 31-3-5, and these duties include permitting of new systems, evaluation of the system for the building lot, including topographical features and soil quality, and also includes ongoing inspection of those systems. The food service statute is found in Title 26 under the Food and Drug title, and it tasks the counties with permitting and inspecting all the restaurants in their respective jurisdictions, and that includes ongoing inspections and grading of those restaurants. On swimming pools, similar to the on-site sewage management duties are those regarding swimming pools, and that statute is located at 3145-1 through 13, and it involves evaluating the swimming pool systems, where it's going to be placed, and then ongoing inspection. The mandated duties regarding disease control, quickly, Chapter 19 of Title 31 places the primary responsibility for rabies control in the county boards of health. Tuberculosis control is found in Chapter 14 of Title 31 and requires the county boards of health to obtain commitment orders for TB patients who resist treatment. So they have to follow these patients, make sure they're taking their treatment, and if they don't, they may have to resort to getting a court order and having them confined until their treatment is finished. Duties regarding sexually transmitted diseases, including HIV, are found in several statutes. 3117.1 requires testing, assuring treatment and notification of contacts, and then continuing those contacts may also need treatment. Titles 16 and 17 include provisions for testing persons convicted of HIV transmitting diseases. Whether they're incarcerated or whether they're on probation, the county boards of health have to find these people, test them, and in the case of where we have victims of rape or molestation, the victims have to be tested and counseled. Immunizations, while there's not a specific mandating statute, under the provisions of 3112, the division is tasked with controlling hazardous diseases and Under 3135, the county boards of health are required to secure compliance with the rules and regulations of the department that have local applications. So under this mandate, the county boards of health oversee the immunization of children specifically and other immunizations that may come up. And under the school rules, they're make sure that all the children who enter school are immunized. And then the emergency medical services, that's on the next slide. Well, that isn't on the next slide, but the emergency medical services are basically enforced at the local level, and that is ensuring that there's ambulance coverage throughout the states and in the various emergency management regions. Now, the general mandates of the county boards of health, as I said, are found in Title 31, Chapter 3. And that title specifically says, these are the broad mandates, to determine the health needs and resources of its jurisdiction by research and by collection, analysis, and evaluation of all data pertaining to the health of community, a very broad mandate. Second, to develop, in cooperation with the department, programs, activities, and facilities responsive to the needs of the areas. Third, to secure compliance with the rules and regulations of the department, specifically the Division of Public Health, that have local application, which, as you can imagine, is many. And to enforce or cause enforcement of all laws pertaining to health, unless the responsibility for the enforcement of such laws is that of another agency. And then there's one further very broad mandate under this same title for counties of public health. No population area or unit of this state shall be without health services responsive to its needs. And that is found at 31.313. Any questions?
Yes. Representative Stevens?
Yes, sir.
A couple of questions, if I may. I saw we've got a mandate for tourism. How does that fit?
I'm sorry, I skipped over that. That's the tourist accommodations. That would be motels and the restaurants that are associated with it. The environmental health section must assure the sanitation of those facilities and issue permits.
And one more, if I may, Madam Chairman. I know that the Health Department provides tuberculosis drugs to the local jails across the state, like INH and B6. Is there a provision in there, since they're holding these people until trial, primarily? Is there a provision for HIV drugs for these inmates?
I believe there is in Chapter 45 under corrections. I know there's a requirement for testing.
Would that be the Department of Human Resources? Okay.
But it mandates the county boards of health have some duty in that.
I have a question. What code section is this, or statute is the grant and aid formula funding in?
I don't know that. That's David Martin will be getting into
Okay.
that.
Thank you.
Thank you.
Okay.
One more.
Representative Rogers.
Thank you so much, Madam Chair. Someone was kind enough to put into our packet the infant deaths and infant mortality rates by county and so forth and so on. Under the slide that you showed, mandated communicable diseases and control, rabies, tuberculosis, et cetera, do you have data on by county of what the state average is, and then what counties are meeting or exceeding each one of these state averages?
I don't know, Dr. Brown. Would that be epidemiology?
I'd appreciate that.
Almost any particular issue that you wish to explore. Let me just, we actually have a website that has information at the county level adjusted for population, and it specifically has mortality figures, hospitalization figures, and emergency room visits at those hospitals. And so that information we can crank out for any condition or entity that you might be interested in, both by state total as well as the subsets of those by county or public health district.
Thank you.
Now we hear Dave Martin, the Chief Financial Officer, for just an overview of
Good morning,
public health budget.
Madam Chairman, committee members. I'm just going to give this morning a brief overview of public health finances in Georgia as a whole, and then I'll be back this afternoon to talk more about the particular formula, the grant and aid formula, and how it's what we've tried to do with it. This chart is a picture since fiscal year 2000 of what the public health Division of Public Health Resources in Georgia have been, and it's got three lines, one for other funding at the bottom. The center line is the state funds appropriated to us, and the top line are the federal dollars that we get. And if you look, you'll see a couple of bumps in there in some of that funding. For example, in other funding in 2001, it shot way up. That's when we started receiving tobacco settlement dollars under the Master Settlement Agreement. And you can see those dollars increase, and in 2006 take a big decline in the amount of tobacco settlement funding that we receive. You see state funds, the big bump in 2002 for federal funds is when we first started receiving bioterrorism funding from the CDC and HRSA for hospital preparedness and for emergency preparedness. Okay? And if we look at 2006 by itself, this is just a pie chart that shows the top 10 sources of money that the Division of Public Health gets. Our final budget last year was a little over $626 million. The largest piece of that is WIC. Now, $237 million worth of WIC. $197 million of that is simply the redemption of the food vouchers that are issued to the clients that they take to their local retailer in exchange for formula or cereal or orange juice or whatever it is their WIC prescription entitles them to. So that's just a pass-through basically that the division receives to redeem those benefits at the local level. The other $40 million worth of WIC is what we actually use in the state to run the program. The state base shows $149 million. One of the interesting things to understand about that is that when the year begins, 42% of those dollars are already spoken for. They're already spoken for because they are matching federal funds, or they are maintenance of effort for federal funds that we're required to spend in order to receive those federal dollars. So when we start the year, 42% of that money is already spoken, pledged basically to programmatic areas for federal fund sources. And if you added those together like I did when I was looking at it, really those top 10 sources of funds add up to 92% of the total public health budget in the state. Okay? Now the first chart you saw was a chart that showed the increase or decline of different kinds of money that we receive over the last 7 years. This chart simply shows you the impact of the population growth in the state over that time, and the fact that what a dollar would buy in the year 2000, in the year 2006, it only bought 85 cents worth of services due to inflation. Not really going to dwell on that a long time. Now we get to grant and aid funding. The first thing, this is a part of the public health budget. It's not the whole thing. This is just the piece that we continue to call grant and aid. Up until 2005, you could look in the appropriations bill that the legislature passes each year, and you could see a line item in the Department of Human Resources budget that said public health grants to counties, $100 and whatever million. You could flip the page and see in the functional budgets the same thing represented as a functional budget. Here's grant and aid to counties. Since we went to program budgeting in 2006, grant and aid no longer exists. You will not be able to find that term in the Department of Human Resources budget anywhere in the appropriations bill. Those dollars were actually spread to the actual programs that the budget is broken down into, like immunization, environmental health, and so forth. Okay? Now, let's just talk about these $2, these two lines that we still say represents grant and aid. The bottom line is what the whole basis of this study committee is about. It's the money that gets allocated. It's called regular grant and aid. It's allocated to all 159 counties, and it's our belief that the intent of it is to provide those mandated services that Amy just talked to you about. So we take that in 2006, $64 million, and based on the formula that we'll talk about this afternoon, we allocate that money to all 159 counties, and we continue, even though we're dealing with program budgeting, we continue to allocate them those dollars as if program budgeting did not exist. And what I mean by that is, you heard last week the stories from the local communities that they're all different. Their needs are different. So we can't take that $64 million and give everybody their pro rata share and say this is for immunization, or this is for environmental health, or this is for family planning, because each community is different. They take it and use it for those things as their local community needs dictate, and they report that back to us, and we turn it back into program expenditures and report it back to you at the end of the year. Okay? The programmatic grant and aid, the bigger number, is given to the county, is given to the 18 health districts. We do not send that money to all 159 counties. We give it to the health districts, and they receive those dollars for specific purposes. It may be WIC, it may be immunization, it may be family planning, but when they receive those dollars, they're targeted at a particular service, and that's all they can use them for. And that lead county in that district, in return for receiving that money, is responsible for making sure that that program exists in all the counties throughout that health district. Whether that's a single county district like Fulton or DeKalb or Clayton, or whether that's one of our multi-county districts that may have 16 counties in their area. Okay. 2 more slides. Programmatic grant and aid, this is a chart that just shows the top sources of the money for what makes that up. You know, when we say we send it to them for specific purposes, 24% of it's to run the WIC program. You know, we had $40 million worth of WIC left over that was not direct benefits for clients. We send $35 million of that to the districts. We send them money for bioterrorism preparedness. The TANF dollars they primarily receive to provide family planning services. The infant and toddlers grants, also known as Babies Can't Wait, and so on. So the programmatic dollars go for specific purposes. Most of the state money that's included in that slide is actually match for those programmatic dollars. Because, for example, the infant and toddlers grant requires a match. They get both the federal money and the state match that goes with that. But it has to be used for that program. And then regular grant and aid, again for 2006, up until about 3 years ago, regular grant and aid was all state money. And then as changes were made in the budget and things were refinanced, regular grant and aid is now composed of actually the $64 million that we had in 2006 is 87% state. There's about 9% TANF in there, and there's some Medicaid administrative money in there. Okay. That's the money that all 159 counties get. And the last slide that I want to talk about this morning is the County Board of Health expenses. Now, the purpose of this, if you added these 4 numbers together, it totals to a little over $401 million that county boards of health spent last year providing their services. 15% of that money came from us in the form of regular grant and aid. 33% of it came from us in the form of programmatic grant and aid. The other 52% of the money that's spent in local boards of health comes either from county government or fees and other income that they raise themselves. Okay? Does not come from DHR. And with that, unless y'all have some questions, that's the basic overview of the funding of public health.
Thank you. Representative Stevens?
Can we get a number of, I guess, the input from the counties, how much they put in, each individual county?
You're going to hear, we have, I think we've already provided that information to
I'm sorry, what was the question?
to the committee.
counties, how much they put in?
The information that I sent on Friday
Okay.
includes the total expenditures and revenues for all counties, for all programs for 2006 and year-to-date through October for 2007.
Does it break it down by county?
Breaks it down by county, breaks it down by program. Yes.
We just got that Friday, so we'll get you a copy of next page.
Good.
Other questions? Yes, Representative Rogers?
Thank you. You know, during this holiday period, I hear stories of, everybody gives to charities and things of this nature, and a certain percentage go to administration of the giving, and a certain percentage actually make it in the field. Do you have a breakdown of strictly administrative and employee cost versus what percentage of these dollars actually make it to the people that they were intended for? And does that change from district to district?
It certainly varies from district to district. We have at the state level, because Public Health Administration is a sub-program within the overall administrative program of DHR, we have the totals and the people that make up the administrative program in the Division of Public Health. It's roughly $16 million in total funding for fiscal year 07. About a little over $13 million of that state. Now, that sounds high, but the bulk of that $13 million worth of what we call public health administration goes to the local level to fund the district health director, the district program manager, the administrator, the environmental director. It goes to the local board of health to actually fund the fact that we have to have an administrative structure in each of the 18 health districts in the state. Only about $2.5 to $3 million of it is not spent at the local level.
So what percentage would you say of the total budget is used for administrative costs?
Of our total budget, well, it's whatever $16 million is out of about 630. Right. But there are those that would, there are those that would debate what we really mean by administrative costs. Do you mean, are you talking about pure overhead, like folks up here at the state level that process bills and, do that type of work? In our administrative budget, we actually include the health directors and the program managers and the people who actually direct the activities in local health departments as part of the administrative budget.
And I'm sorry, the second part about the difference between one district and the other.
Well,
what is your accountability on whether one district gets a little too expensive administratively? How do you?
Basically, the difference in administrative costs from district to district that the state funds is based on the longevity of the people that are in those jobs. Health directors that have been there longer, that are making a higher salary, or the same goes true for any of the other levels of position. That district's going to have a higher level of administrative funding that we participate in than another district would.
Did you have a question?
I do have a follow-up, Madam Chairman, and it has to do with the map that we've got. I can't remember if the last time we met if the cost that the state provides its dollars in the state, if it was broken out by both congressional district and the public health district.
We don't have it broken out by congressional district, although we could do that by grouping counties together, assuming the district boundaries follow the county boundaries. It is broken out by those 18 public health districts in the information that was furnished on Friday. Okay. I mean, you can look at that at the county level, you can look at it at the individual district level, or the state level as a whole.
I have a question. I know you showed on the slide where the grant and aid funding has decreased, the regular grant and aid down to 64
Yes, ma'am.
in '06. And then on your two slides after that, we see where the Georgia's share actually has decreased because we've been bringing in federal dollars. Is that correct?
Georgia's share of,
Basically what we've been paying, you said the state base is 55.
well,
You said in '06 we began
it really
bringing in
decreased
TANF
because
funds and Medicaid.
the biggest decrease, the reason for federal money getting into regular grant and aid was back in the supplemental budget for 2004 and the initial budget for FY 2005. TANF dollars replaced state dollars in the family planning program in the Division of Public Health. That's the main reason that it was basically a dollar-for-dollar swap of state for TANF dollars because back at that point in time, the state was in a little budget crunch.
Okay. Any other questions? Okay. Thank you.
Okay.
Yeah, for the. Now we'd like to hear from Dr. Minyard with the Georgia Health Policy Center. Just pretty much just discuss the demographics in Georgia. If we can get copies of everything we got on Friday, it would be great if I can get them in their hands. We appreciate you coming today, Dr. Minyard. You did a great job at the biennial. That's okay. No.
Today I'm going to talk some about the core business drivers of public health. This is information that helps us look at the broad view of public health, thinking about the big picture, and then thinking about how issues such as the one that you're facing, the grant and aid, fit within that bigger picture. The information that I'm going to share with you comes from research that was done by the Health Policy Center over a 10-month period of time to examine some issues related to public health in Georgia and put it within the national context. So we would be looking at describing the core business of Georgia's governmental public health and thinking about these findings as they might inform a broad system change. And the research questions for us were what is the current core business of Georgia's governmental public health, and what is the ideal core business of Georgia's governmental public health agency. And in the state context, we were looking at information that I'm sure you have already seen, which is how many residents we have. We're relatively younger and more diverse than other states. 13% of our population lives below poverty level. We have poor health status. We've moved from 43rd to 42nd this year, but our maps that track our health status makes us look like we have poorer health status than we had in 2003. We have disparities. We have more than 1 million on Medicaid. We have 1.7 million uninsured, and we have limited access in rural areas. This is a context that we look at when we think about Georgia as related to other states. In Georgia, the public health is responsible for the communities and the 8.8 million Georgians. There are numerous branches, sections, programs, and offices, and I'm going to say a little bit more about that. 18 health districts, 159 county departments, and responsibility for some comprehensive, demanding programs: WIC, bioterrorism, TANF, Title 19, maternal and child health, AIDS prevention, and HIV care. The public health infrastructure, from sort of the simple, broad way, a number of staff, 6,000, a large budget, and 2004, and I know y'all have looked at some later budget numbers, and per capita health spending of $7 per person. In this work, it was a case study approach. The primary unit of our study was the state public health agency. We also had secondary units which had to do with the district and local health agencies, and also issues such as how the money flows, what are the collaborations, what's the structure, what's the strategy, what are the staff perceptions. We also looked at the political, the economic, the financing, and regulatory environments, as well as the stakeholder perceptions. We did multiple interviews with internal and external stakeholders, about 69 of those, and did 6 focus groups throughout Georgia that had 86 participants, as well as reviewing numerous archival documents that had to do with the regulation of our public health and the financing of our public health. In these external stakeholders, we interviewed key leaders through the state who interface with public health, as well as legislators and people at the local level. The research process was one that was a 10-month duration. It was a practice research partnership in that we were in partnership with public health as we were working on it, and they were validating and helping us understand what we were hearing, that we were debriefing with them as we went along and attempting to build a community of practice. There are several findings that are key to the work that we did. This is a chart that shows the perceptions of the leaders in public health about where they currently spend their money and their time and what they really have to do. And it is targeted and looking at the essential services, and I think you've probably heard a little bit about that, and you have in your packets a list of the 10 essential services that are in layperson's terms. These are more public healthies, but what this shows is that the perception of the leaders was that the things that are the current way that they are driven to do their work is the blue part. And the way that it would be ideal for them to allocate their time and resources is the red. And in every way, except research, you can see that what they think the core drivers and ideal resource allocation should be is the mirror image, the opposite of what it actually should be. And the research is an exception. And of note is the assure, access, and link people to needed personal health services is very high in resource allocation. And given everything else they do, they thought that it should be lower. Some quotes that came out of the work that were sort of descriptive of the overall information. I believe that we are allocating more of our resources to this linking and providing than is appropriate. Our role ought to be cultivating the resources in the community to solve those needed health services problems and working with communities to improve health status. The second principal finding is related to this first, and that the current drivers are not aligned with the ideal drivers. And so the current drivers are money, and the way that the money comes in these siloed streams, the safety net and the fragility of the safety net, the uninsured, the number of uninsured that we have and where they're located, performance-based budgeting, regulation, and leader philosophies. And what the drivers ought to be are the need, what are the practices that work, what is the state strategy that is informed by the local perspective, and what is the local culture. And so this is a bigger problem than deciding about one funding stream. It's a problem of looking at what do we want for public health in our state, how is it set up now, and how do we want to restructure it so that it works in the way that we want it to. And I think this committee is a very important one because you have the opportunity to take a step back and look at the bigger picture of public health and to think about how does it fit within other issues that we face in the state, and what are the things that we need to do that align the drivers in a way that helps people do the work that they need to do in public health. A part of this is the funding. And again, you have seen, I'm sure, very specific funding information. And this is more, in my part, an illustrative information about funding. The amount, and I know the dollars are somewhat the same, how much of it is state and how much of it is federal. And this is a depiction, and this is another thing, that the dollar figures are estimates. They were pretty accurate when we looked at the 2004 fiscal year. The thing about that, that's important, is that when you look at the grant and aid just below that box that says Division of Public Health, you see that in the whole picture of everything, that is a limited part of what public health is dealing with when you look at this money. And so you can see they're federal funds, and they come to the state and to the county health departments and to the district in a very complex way. And some of what is a challenge is that when there is a broad mission, or if you're trying to make a broad mission, but you get the funding in these categorical streams, it makes it hard for you to focus on the broad mission that you seek to accomplish. And just to show, I think it's valuable to see how much there is in state, federal, state, and state funding that goes to the Division of Public Health, and then the complexity of the money that goes to the counties. And there are things that are causing this to change. When we've changed the state block grant, when we've changed the tobacco fund settlement, when we have changed the grant and aid, when Medicaid becomes managed care and doesn't work with public health in the same way, and then both these public insurance and user fees end up being different locally, it changes the situation, and the public health folks have to react to it. The third finding is that there is a call for public health leadership and collaboration. There's this desire for public health to rally everybody and lead us to better health. And this was something that was said over and over by key leaders in the state in multiple ways. We think it is the job of public health to lead us out of the poor health status situation that we are in Georgia. And it's kind of the three key points for this. One is the public trust the work of the division to protect the public's health. Now, they might not understand exactly what that is. Like, what is the mysterious thing, set of activities that they do to keep us safe? They don't understand all of what it is, but they trust that public health is going to keep us safe. They are calling for simple, clear, and compelling messages from the division. Now, it is very difficult to give a simple, clear, compelling message when you have a budget like the one that they have, an organizational structure like the one that they have. It's hard to translate that into something. I mean, you have to have right now just 2 days just to hear about it all. It's not simple. And then there is this call for the division to lead the state in improving the health of all people. I just put this in because it illustrates this point. This is the simplified version of the organizational chart. And even that is very complex with the districts and the communities, the counties, and it's not so much to look at every detail, but it's to understand the job that they have in moving from a complex organizational structure, regulations, and financing to something that simply says to you and to everybody, this is what we're trying to do. A big part, sort of a theme that came out of the work was public health needs to build the safety net rather than be the safety net. They are not equipped from a staffing or financial perspective to be able to do a good job at being the safety net. Part of that is because the number of people who are uninsured is on the rise, and I took these out of your presentation from the biennial. We see that we have grown by 200,000 uninsured this last year. The components that make up the increase in the uninsured are many and complex, but three key themes are the rapid increase in the uninsured for ages 18 to 24, the decrease in employer offer rates and in employee take-up rates, and especially a creeping change in the large business's ability to match up with the employee on insurance, and a tripling of the number of uninsured non-citizens, which takes us to having 20% of our uninsured as being non-citizens. So we have a complex growth in the uninsured, and that puts incredible pressure on every single public health department locally, because they are faced with trying to deal with these people who come to them in a last resort. I remember one story from one of the public health people who was working in a rural community, and she said, you don't know what it's like to be the person in the public health department and have these folks come to your door who are elderly or poor, and you are their last resort. They have been everywhere else, and they have a need, and you have literally, standing with them human to human, no resource to offer. And it illustrated for me the challenge that people in Georgia who are working on the fringe of the safety net face as they try to figure out what to do with the reality of 1.7 million people who are uninsured. And we know that the people that are uninsured are more likely to have poor health, more likely to miss school or work. In fact, they miss twice as much school or work in our survey, our population survey, as do people who are uninsured. They don't get as much preventive care. They don't have a usual source of care. That's why they're going to public health. They're sicker when they're admitted to the hospital, and they're more likely to be readmitted. So some of the things that people said, it only makes sense to deliver health care through the health department until something better comes along. If we don't do it, who will? Knowing that people don't have health insurance, there's got to be access to care. Public health is one of the only options. And we have other options like fairly qualified community health centers and physician volunteerism. I think those things partially address the problem, but it's a complex set of issues that make it so that the folks in public health are sometimes have to be focused on the immediate issue at hand and aren't able to turn their attention to what they see as their real primary mission, and that's leading us out of poor health status. I've used this healthcare bucket in several settings, and I think it's applicable here. Because what we have a situation is thinking about health and economic development, and what we want to do is we want all the money that we can get into the health bucket because it's an economic engine for local communities, and we want to create this situation where we take care of people and it's paid for, and we have an economic engine as health. But we have two big holes in our bucket. One is the uninsured, and one is the poor health status, the general poor health status of Georgians. So what we have for public health is they are spending most of their time ineffectively trying to plug the uninsured hole, when what we really want them to be doing is to plug the health status hole. And they can't do that. And when you look at what's happened, even though we've gone up from 43rd to 42nd in the United Health rankings, we still have a darker green. And one of the things we do, we look at this map and we say, the darker the green, the poorer the health status. And for the last years since we first did this map in 1998, I've been singing the song of a lighter shade of green. All I want is a lighter shade of green. And you could imagine my disappointment when I got this map updated 2 weeks ago. It is not a lighter shade of green. It looks worse. Part of the reason it looks worse is because this map is referenced to the United States. And so it compares our health status as it relates to how we compare to all the other counties in the United States. And we're not our health status is not improving. So, in conclusion, the practice preferences in Georgia are not aligned with the theoretically ideal essential services. And the core business is not aligned with the ideal. And there are systematic changes or challenges within the system that make the ideal difficult. And moving toward the ideal is going to require addressing the larger system drivers. Understanding the drivers and their impact is essential. You have to look at public health within the larger context, which includes the uninsured, the viability of the safety net, and health care financing. Part of that is our changes in Medicaid. The emerging role for public health to participate in and even lead broad policy conversations. And so the propositions are addressing the systematic drivers may be at least as important in improving public health as changing the structure and processes within the public health agencies. So you are in this perfect place to do the kind of work that's needed this time, and that's to step back and look at the the larger system drivers, and to think about how this system fits with public health overall.
Thank you, Dr. Maynard. Any questions from the committee? Okay. Representative Stevens?
It's pretty disappointing in the amount of poor health for Macon below in the state compared to 2003. Have you got some sort of idea of what it has cost public health departments since managed care has come into being?
I think that, let's see, Sonia was talking to me a little bit about that last week, that the changes in public health reimbursement with Medicaid are significant. And if you look at that chart earlier that shows what percentage of their money comes from public and private, and let's see, I don't know if I can get back to that one. And the user fees, I think they may be tied up somewhat in Medicaid. It's going to be significant, so you might want to. Oh, I think it's on your agenda to hear that detail.
Any other questions? Okay. Representative Rogers?
Thank you, Madam Chairman. The blue and the red chart that you showed in regards to allocation, I don't think in 4 years of office I've ever had anybody come up to me and thank me for being fully funded. Did you put a number to the red?
No.
If it was a perfect situation, how much would it cost?
I think that would be a valuable thing to do, to look at that and say, what would we need? But we did not put the number to it.
Okay, and may I continue? Have you looked at other states that perhaps are more in the idea of resources allocated and check their success rate on the services provided and the health of their citizens versus that?
We did look at a lot of things related to other states, how they were structured, how they were focused on the 10 essential services, and also looking at their quality. A lot of states are entering into measuring the quality of the work at different levels and being credentialed in public health. So there's a lot going on across states. The one thing that is a challenge for us in making the comparisons is that a big part of public health has to do with the population and the demographics of the population. And while some other states may have been able to make progress with a lesser investment, they may not have the same health and uninsured problems that we have that put so much pressure on our system. So I think it is possible to look somewhat at what other states have done and how they've handled it, but we'll have to modify any kind of pricing estimates to match with our population.
If I may continue, in education you always have what's called a comparison group, where you don't compare inner city Atlanta schools with perhaps a more affluent area. Given that as a kind of a base, I'm assuming that you do have other states. When we get ranked, so I'm assuming we've got other states that match up.
We've got the other states that are in the bottom 10 with us.
Fairly close. But I've got to assume in each one of those silos that you referenced that we do find some states that do a better job in some silos, and Georgia probably does a better job in some of those instances as well. How do you make that comparison between the two to make sure that we're getting, frankly, the most bang for our buck and that we're as effective and as efficient as we can possibly be?
Well, I was thinking about other projects where we have done comparisons where we choose states that either have done really well. We did this with the uninsured at the biennial, states that have done very well, or states that are similar to us, and compared what they've done and what it would cost, and also looked at the demographics across our state. So it sounds like you're calling for that kind of a look.
Yeah,
that I don't have the answer to.
When we say we're 43rd, I'd like to know if there's another state out there with a 20% or close to it. What's the closest match to us? What are they doing that's successful? That way we can turn around and perhaps even internally see if there's areas of improvement or what we're doing right or what other states may be doing right that might help us. And then ultimately come up with a plan, a vision of where we need to go financially with this to get to the levels that we're currently not at.
It sounds like you're looking for what are the best practices in other states, especially the best practices in states that are like us. There was a small component of this report that has a little bit of that information, but it sounds like you want more depth than we have done so far.
Okay, Representative Chanel.
Thank you, Madam Chairman. Dr. Minion, on page 5 of your handout, Principal Findings 1.
Mm-hmm. Is this the 5th slide?
That one. They assure access and link people to needed personal health services, according to this slide, is where we spend currently the most money. And the ideal resource allocation, according to this slide, and I'm unclear who are these people.
This is the perception and the assessment of key public health leaders, the district health directors and other key leaders in public health who were assessing, here's what we are doing and here's what we think we should be doing based on what we know is going on nationally.
So, in other words, then, according to them, this slide seems to indicate that what we are spending the most money on, the leaders in the healthcare community apparently think we should spend the least amount of money on. Is that right?
Right. Right.
Thank you.
Okay, I have a question. I know you talked about the 10 essential services and added the mandates, the federal mandates. Where did you basically talk about providing health care services and improving health, but where does bioterrorism and public safety come into play as far as funding? The CDC has said, since 2001, public health has changed drastically in the nation. It's no longer just focused on prevention, but also on public
Right.
safety. So was that?
I guess it would come under, in the 10 essential services, the laws and regulations. Is that where you put it?
Put it under the,
Well, it kind of flows through a lot of them.
yeah, it's really trying to assure that you have a public health infrastructure that can respond. And so it relates to all of these early pieces. For example, to answer that question specifically, our ability to quickly identify an outbreak and to identify what's the cause of that outbreak is an essential component of preparedness, for example. And we've invested a fair amount of effort and money, frankly, into that kind of a process. And so that's a piece of what's here on diagnosing and investigating, for example.
And Dr. Min, in your studies, did you find that the current funding, are the dollars going where the people are, or?
Yeah, that's the challenge of the grant and aid, is how to figure out how to have the right allocation of resources. And I don't have the answer as to how that should be structured, except that it would be better if we could look at the funding from a bigger picture and say, these are the things that we want to accomplish, and these sources of money will help that, and we need these parts of it, and then we need to structure this money to do this other part. But because we have a population growing, poor health status, and more uninsured, I would venture to say there aren't the amount of dollars in the system that are going to be needed.
Okay. Any other questions? Okay. Thank you. Appreciate you coming and sharing with us today. Do a break or keep going? Thank you. We're late. We went through our break. Okay. Now, Ty Carlson, please, with the Cobb County Administrator. I think we're going to work through our break, guys, if that's okay.
To be able to move these slides. To walk it down.
Probably. Yeah, that's it. Okay, thank you. Little did you know that you'd be in charge of that.
Thank you.
ready?
Appreciate you coming today. Yeah, sorry.
My name is Ty Carlson. I'm the Director of Administration for District 3-1, which is Cobb and Douglas County. Let me give you a brief profile of these two counties. I'm going to be talking more on the large end of it, but I also want my presentation to go really throughout all the districts and counties, because the main sources of revenue and the main problems we're having on the expense side really pertain to large counties and small counties. Quick synopsis of mine. Again, I'm one of the larger counties, 664,000 people. Douglas has about 113,000. Growth rate since 1970, about 237%. Douglas, about 300%. I've got 57,000 Medicaid people in Cobb County. About a third of them pass through the health department every year. I see about 100,000 unduplicated clients in the health department of Cobb County. My makeup is 47 white, 27 black, 21% Hispanic, and 4 other. And about a third of the visits into Cobb County are Hispanics. I have 330 people in these two county areas in about 6 locations. My budget is around $23 million. Now, that's all of the public health and the categorical money that we spend. That $23 million funds about 43 projects or programs. One of those programs is public health, and that's what I'll be talking about today. That is funded by the formula. It covers our essential services and some other things. Out of the $23 million, $8 million is public health. Again, I'm at the larger end of the spectrum. Again, our health departments go to 3, 4, 5, 6, 7 people, 10,000 people in the county. So but again, the funding elements and expense problems that we have are the same regardless of size. Nade. Grant and aid to Cobb County represents around 37% of the public health budget. It's a significant source of revenue to all county budgets and all district budgets. We have been negatively impacted the last 3 or 4 years by cuts in the grant and aid. Cobb County's cut over those 3-year periods was about $500,000, which I had to find, again, to keep us going. This revenue source, unfortunately, is not adjusted for inflation and is not adjusted for the population increases. Another significant revenue source in my public health budget is the county contribution. The county provides public health in all the health districts with their facilities. So that's a big factor, big positive that the counties do for the county does for the county health department in the districts. They provide all of my facilities, although I do have to pay utilities and janitorial and those types of things. They just, if I have something wrong with the air conditioning, they'll come and fix it. That's a nice factor that they do for us. They also give us grants. Each county gets a county grant.
This varies across the board. Let me just tell you a little bit about Cobb and Douglas, and then I'll tell you about a couple of others that I hear about. The grant that Cobb County gets from its government funds around 12% of the public health budget in Cobb County. This money, the dollar amount, has not changed since 2000, so it's pretty static. Douglas, on the other hand, funds around 30% of the budget. I do ask for cost of living increases with Douglas County, and they do fund those to 2.5%. Matter of fact, during the reductions in grant Nade, I asked them for a little bit more, which they allowed me to have. So, again, and just in my district, I've got one that's very responsive, and then I've got one that says, take care of it your own, only come back to me if you really have a problem. And, of course, my board says try to take care of it, which again, we will try to do, and I'll explain that when I get to the fees. Again, the counties vary across the board. There is a formula that the counties were supposed to give in relationship to their grant and aid. This formula is was in effect 30-some years ago, and really is not in effect now. All the counties, most of the counties get more grant and aid than is required, but there are several counties that I've heard are right on that cusp of what the formula was 30 years ago. So this is something that I think needs to be considered, is the county is funding. Some are very responsive, some are not responsive, but there is a source here of additional funds or some sort of contribution in relationship to grant and aid. It does vary across the board. Fee income is very important to the districts and the health departments. In Cobb, it represents around 31% of the public health budget is in fees. Again, this is one area that I've got some control over. I don't have control over grant and aid. I don't have control over the counties. I can try to influence it, but fees I do have some, but it's limited. Our biggest fee is environmental health, but in many cases it does not cover the cost of that program. We heard the other day that DeKalb, only 40% of their environmental health was covered by fees. Mine is 70% in Cobb, 55% in Douglas. The last 4 or 5 years since I've had cuts in grant and aid, I have looked at my fees carefully and looked at where my fees were in relationship to the other metro counties and have jacked them up as much as I can. So I'm getting closer to the competitive level, I guess, in Cobb County. So I've gone from maybe 40 to 45% up to 70%. I can't squeeze much more juice out of that orange. Fees in all of our cases, in most cases of the Board of Health or with the districts, we have a sliding scale. The sliding scale for fee adjusts based upon a client's income and their family size, so that, again, we can charge the proper fee to a person that can pay for it, and if somebody comes in destitute, we'll give them a much reduced fee. Fee increases are very difficult to put through, again, because a lot of our clientele are the underinsured and non-insured. So it's just something that I can't turn on and turn off or turn down when I need it. Where I can, I try to get as much fees as I can because, again, this is about the only thing that I've got available to me in my budget from a revenue basis that I've got control over. Again, my control, though, is limited because of the people that I see. Big thing I've got to do is I've got to collect. So I concentrate as much as I can on making sure that everybody knows when they step into the health department and are owed a fee, I get paid that day. I can't put them on receivables and send them out an invoice because I never get it. There are some services that I perform that I don't charge fees for. I listed 3 of them up here in the infectious disease area. Obviously, all of our epi surveillance is all done without fee, and some of our follow-up visits, and there are quite a number of other ones. Let me talk for a second about Medicaid. This is a large portion of our revenue. For Cobb, it's around 13% of our revenue. And again, it's something up until recently that I had some control over. Because I've been cut in the grant and aid process, because I can't rely on the county to fund me when I need it, I have had to, again, look at my fees very carefully and look to Medicaid. I've looked at Medicaid very carefully the last 4 or 5 years and have tried to milk every drop that I can, because every person that I've got on my staff, if I can get an additional dollar of revenue from someplace, it's just something that I can enjoy. I don't want to add people. I want my people to be revenue generators, and they have been in Medicaid. So I've increased this up from probably 9 or 10% to 13% of revenues. June 1st, we had a big shock in Georgia from a public health standpoint. Now, maybe from a Medicaid and DCH standpoint, it was probably fine as the Medicaid, hopefully the Medicaid costs come under control. But for public health, it was a tremendous shock. I had forecasted a reduction this year of 20% in my Medicaid fees, just thinking that I better be conservative. Well, I wasn't. I was not conservative enough. The reduction to me is probably going to be 30 to 35%. When Medicaid managed care came into Georgia, everybody was found a primary care home, and again, those primary care providers are trying to take care of as many services as they can, which in many cases used to come down to the health department. The big thing is our collections have been severely impacted this year. These additional organizations, our systems are not the best in the world, but when we have to match them up against systems that are equally as poor, and there have been a lot of them, the match is just not there. Even after 7 months, we still don't have our billing squared away. I have collected about 20% in 7 months that I have billed. This has really been a very, very tough thing. Hopefully this will settle out. But one thing I know, it'll settle out with a reduced Medicaid revenue to the districts and to the health departments. Again, I'm going to have to try to make that up, lay off people, do something, switch my services. That's my budget challenge for 2008. District expenditures, those are the key elements of my revenue. On district expenditures, let me go briefly into to what we look at from a health department from the expenditure side. It's pretty easy. 70% of our expenses are salaries and benefits. We are part of the merit system of Georgia, so when there's a yearly annual increase of, let's say, 2%, we are required to fund that. The money that we get for funding these merit system increases is less than 50%. So again, that's something that we always have to do every single year, is fund our salary increases. We have inflation, benefit inflation in our benefits. This year, our medical went up 20%. For me, it cost about $120,000 of additional money I had to find in the Cobb County budget. Again, I've got no control over this. This is given to me by the state, but again, they don't give me any money for this. This benefits, obviously, is our retirement, our medical, and any increases the federal government has in FICA. Anything that happens in these, and again, the trend is up, I've got to find money out of my own personal budget. Also, the districts are getting upward pressure on salaries because we have to offer higher salaries to people when we hire them, especially for key positions. Our turnover is very poor, very rapid. We're asking our people to do more with less, which means we have to have higher quality people. So I do see this, especially in the metro area where there's more competition for folks. I've got to pay more money. I see my salaries edging up just to get good qualified people that will stay with us. Again, our base salaries in the state have been kind of low. We are trying to escalate those to the extent that we can in those key positions where we need good quality folks. Again, this is another upward thrust. Other expenditures is about 30% of the budget. And again, this will vary depending upon the district or health department. 70%, 75%, 65%. Again, this is probably pretty reasonable. 30% is other expenditures in the public health budget. Travel and utilities are energy-based. If you realize 2 years ago the per diem cost was 32 cents a mile, and then it went up to 48. We had to eat that very quickly, find money for it. Medical supplies and pharmaceuticals have a higher inflation rate than the general inflation rate, and again, that's what we do. In all of our other expenses, the general inflation rate, again, for 1 year, it doesn't affect us, but you look over a period of 5 or 10 years, we have to find money to keep up with the general inflation of the various components here. At the districts and at the health department level, we do walk a fine balancing and tightrope. Our revenue sources are decreasing. Grant and aid is not growing with inflation or are adjusted for population. We have no control over that. The county contribution varies. You've got some counties that help, some counties that don't help. There's no rhyme or reason to it. It depends. It's strictly a local type thing. Fees, we have a limited ability to increase those. Medicaid is decreasing. So revenues are not in real good shape right now. As a matter of fact, are on a decline. Expenses are increasing due to inflation, and we're being squeezed at both ends here. Productivity, this is what has gotten us by the last 4 or 5 years. We've had to do a lot more with less. Our productivity has increased. Our management and staff have been asked to do more. We wear many hats, but the rates of this are diminishing. When we get unfunded mandates, again, this hurts because we don't have a system that can handle those very easily now. All the excess has been kind of wrung out of the system. And the big thing is, from our standpoint in Cobb and Douglas, as we look in the future, right now we're looking at what are the biggest causes of death and illness in my 2 counties. And it's cardiovascular disease and all the various behaviors that go along with that. Obesity, exercise, blood pressure, the whole 9 yards. As we look at this and try to make a difference in my two areas, it's going to be difficult to shift money. I mean, that's again one of our big things is we're going to need to shift money from what we're doing now, shift it more toward these types of services, and certainly we need to partner with other agencies in our local communities, and we're going to be trying to do that. Again, that's going to be tough. We have to cover the essential mandated services. We want to do more in the community. These types of things we want to do are not fee-based. So I'm going to have to find the money internally and fund it. That's the challenge that I've got. We'll certainly try our best, but the funding, if the funding can certainly go along with not only covering the essential services, but where we want to go in the state, in our local communities, as far as hitting some of the things that are really influencing our population, we are going to need some sort of different funding because right now it's just not working. The squeeze is there.
Thank you. Appreciate it. I hate to cut you off, but we're running a little bit late. So I definitely appreciate you sharing your data. Do you currently have the SHAP program in your department?
Very, very small.
Okay. Thank you. Dr. Sellers, I appreciate you coming today.
Good morning. I'm glad to be here.
If I could get you to be brief, it would be great.
Okay. Well, I'll be as brief as you'd like me to be. I just want to say I'm really thankful to be here. I work for, I know you all work for thousands of supervisors, every voter in your district. I work for 11 supervisors, Dr. Brown and his staff, and I also work for each of the 10 county boards of health in my district. So I'm one of these characters known as a district health director. I live and work and raise my children in Rome, so I'm here to kind of give you all a kind of a local perspective. And I just want to thank you for the chance to be here today. And I can limit my remarks to 2 nutshell messages and then get into as much detail as we have time for. The first one is that as someone working locally with local health departments in a district level, I really welcome the work that you're about with the grant and aid formula possible change. I do think we need to revise that formula, even though I work in a district that has both slow-growing and fast-growing counties, and I also live in a district, in a working district, which has both suburban, urban, and small-town populations. I do think that we need to do this type of work that you're about. The second take-home message from the local level is just from my perspective, after 22 years in a public health career and 12 years being a district health director in Rome, I have never seen so much responsibility placed on our local health departments as we have right now. It is way above what we've experienced, what I've experienced in my 12-year career as a district health director. And to go along with that, tying in with what you just heard from Ty, I've never seen us so stretched to be able to perform and do the responsibilities that we have in public health in Georgia right now. We are really, literally, if I listen to my staff, we have staff meetings regularly that we're literally at our knees wanting some relief from the situation we're in with regard to our increased responsibilities and the declining and stretched resources. I want to share with you just a brief experience I had as a child that I think might provide an image for how I see the important work we do in public health. When I was a little boy growing up in DeKalb County here in Atlanta, my mother would take me to church kindergarten every day, and on the way to my kindergarten class, we'd pass by the fire department. And each day when I saw the fire department, often I would see the firemen out there playing baseball in the side yard. And I thought, wow, what a job to be able to do the heroic work that fire department folks do on a day-to-day basis, but most of the time get to play baseball. Now, fast forward to my career now, working in local public health, we find ourselves in kind of a fire department role with regard to our protection in the community. We are there to put out the public health fires, the possible anthrax attacks, the possible pandemic flu situation that might be hitting us. Even more, like we just had a whooping cough outbreak in North Georgia, and we are there to help put out those types of fires. And this is the kind of work that, if you're familiar with Stephen Covey's language, it's important, urgent work. That's what the fire department does. In the fire department playing baseball, that's unimportant, not urgent. It's fun, and I understand that fire departments have gotten more into important but not urgent work. In other words, helping communities prevent conditions in which fires might break out. Well, in public health, that's what we do, and that's what Stephen Covey recommends we do with most of our time, is to spend time in important but not urgent work. So we need to spend most of our time promoting health, promoting conditions in which the children in our neighborhoods and our communities will be healthy enough to play baseball or go to school or grow up and be productive citizens. So that's the basic part of our work, is that we do health promotion. We help to fill in gaps where the safety net is leaking. And we also need to be ready because of the immunization work that we do, experience with working under medical protocols. I have about 130 nurses in my district that work under my license, so it's an extremely cost-efficient way of getting medical services out to a community in an emergency situation. But they wouldn't be helpful if we didn't have those 130 nurses who were well-trained and experienced in day-to-day work with immunizations, with working under medical protocols. And my concern right now is we're really close to having some of our health departments fall apart because of the increasing challenges that we have. I'm ready to go into my slides now, and I can go over these as fast or as slow as you'd like, Representative Sheldon.
Run them pretty quickly.
Okay. These are the increasing responsibilities that we've had in the recent years, largely since 9/11, emergency preparedness and response. Our populations are continuing to grow. We are increasingly seeing the impact of the uninsured, the growing uninsured problem. We have new emerging health threats. We know about the obesity problem, chronic disease, aging population, the pandemic flu threat. There are also big problems with emerging infectious diseases that are resistant to antibiotics. A lot of new threats that have come into our work in the last 5 years or so. And on top of that, we have diverse populations. We have to employ interpreters to help us deliver services at many of our health departments. We are shifting to primary prevention. Dr. Brown has told you how important primary prevention is, and that is a new responsibility that we have been gradually shifting into in our health departments. Our staff work in health promotion, and we also go out in the community, engaging in community partnerships to try to recognize that we can't do this alone, to try to form partnerships in the area of trying to prevent problems from beginning, try to keep them from starting in the first place. Decreasing resources, I won't go over that anymore on the financial side, but I would say that you'll hear tomorrow about our nursing staff shortage, and I just want to say that it's real. We've had a decreasing nursing capacity in my district. We also have trouble with keeping fully trained nurses and environmentalists. We have a situation in which our salaries and working conditions aren't as competitive as they used to be. It takes 18 months to train a nurse to be a good public health nurse. And unfortunately, we invest in training these nurses, and often they just take a job for $10,000 or $15,000 at a local hospital or home health service, and we lose them after that investment. Environmentalists take about 8 months to get fully trained. And so we are basically finding ourselves more and more working with staff who are too many of them are in training and not fully able to do the job that we need to have. And of course, the next generation of leaders and managers is a problem. If we have continual turnover in our younger staff, we're not growing those people that need to be able to provide leadership in the future. How is this impacting our services? We have increased waiting times for family planning, for example. We're supposed to get folks in within 10 days. In my district, sometimes it's 2, 3, even 4 months before we have a family planning appointment available. When they do come in, we often give them cancer screening, so this means less folks are getting cancer screenings. More folks are being referred, are showing up in emergency rooms in my district. Some of those problems could be handled if we had more capacity at the local level and health departments. Our WIC program has delays. Children are falling through the cracks with our children at-risk children's programs. And in my district, we've closed 3 stroke and heart attack prevention or SAP programs and diabetes clinics. 3 of my 10 counties have closed those down. The potential impact on services is what I am really worried about when I say we're at our knees. We're not quite on the ground yet, but if we do fall apart with the increased responsibility and the fewer resources we have, we're not going to be there the next time we have an anthrax attack or if pandemic flu does come to this country. Tuberculosis is a growing concern, and it takes experienced public health nurses to be able to handle TB types of situations. And then a really big part is the loss of the ability to conduct emergency clinics, as I mentioned. Impact on the workforce, I've mentioned a good bit of those ideas. I would say that we also have a morale issue at the local level mainly because of two or three reasons. One is just the general pay scales. Second is folks have lost the ability to, as their families grow, to move up with pay compensation throughout a career. We lost those as state employees in the early 1990s. And so we bring young people on, and they get great experience, and they start having children and raising a family. They want to be able to see their salaries grow, not just a minimal cost of living increase, but something to help them with their increasing family expenses, and they're not getting it. The other part about the low morale is that our folks really want to deliver quality services. And they also want to get out in the community and do primary prevention and community partnerships. But what they're telling me right now is they are having to choose between one or the other. Do you want us to roll people through the clinic, meet the federal mandates for how soon we can see folks and deliver the quality services we're required to do? Or do you want us out working with our local mayor and fire department and emergency response folks preparing our community for pandemic flu? Which one? One or the other. We don't have resources to do both right now, and so that really tears on morale at the local level. Impact on Georgia, I can just let you, I know you're educated folks, you know the impact of not preventing problems, injuries, and illnesses before they happen, and the societal and economic impacts of those. Okay. That's what I have, but I'd be glad to share with you. I've also got some information about specific counties in my district, and be glad to share that if you would like.
Thank you, Dr. Sellers. Any questions? Okay. Thank you so much for sharing with us today. Thanks, Dr. Burnett. And we'd like to ask, you would be joining us for lunch today, is that correct?
It'll be my pleasure.
Okay, wonderful. So just to let y'all know, he will be there for questions.
All right, good morning. Thank you, everybody. I should mention thank you to Peggy Honore, because my participation in this has been funded through part of her Robert Wood Johnson Foundation grant. We've been trying for the big pharma funding, but we're not getting that. As you've heard from this room already, they tell me that there's no money in public health. So what I wanted to do briefly was talk about funding formulas, which ultimately is what your committee might work towards. A few of the things that funding formulas should address: need in terms of delivering, you've all heard about 10 essential services, delivering those services to the entire state. Fiscal capacity, you've got to decide what to do about counties that can't, quote unquote, afford it. Equity, there's a lot of different ways to measure fairness: per person in poverty, per person in need. Then you've got to look at what kind of need. Is it HIV, STDs, TB, things like that. So there's a lot of different ways to measure that equity. Also, just in terms of, and we'll talk about some of these measures in just a moment. And lastly, because I believe we've already heard some questions about that, efficiency. Your formula should address efficiency. And I know a lot of people don't like to think about efficiency with health care, but I'll talk about that in a second. So, and I think Representative Stephens, you had a question about this already, about the relationship between funding and performance, and there is. Studies have shown it at the large scale that the news is not necessarily good. Poor funding leads to offering a tighter range of services for financial health, and generally poor health quality indicators, public health quality indicators. Those two quotes kind of tell you the same thing. In addition to these two quotes, I've been doing some research on my own, and I'm finding that, and we'll see it actually at lunchtime, that the percentage, the extent to which local funds are particularly important. In other words, states giving money, very helpful, very appreciated. But there seems to be a relationship between state and local where when the state gives more, beyond match to and the relationship is beyond proportional. So it kind of gives, well, it gives incentives to the state to give more, but one of the reasons is the local funds that they seem to develop seem that much more effective. It might be a level of commitment at the local level, something like that, but it amplifies. There's a bunch of different variables you can look at. Again, going back to the fact that this will be some kind of formula. First one is population. More people certainly is going to increase the amount of need. These are all separate elements. They can be combined and stuff like that, and we'll talk about how different states do it in a moment. One of the important things, larger population is associated with a broader range of services. for health districts. Health districts with small populations don't, statistically speaking, don't provide as full a range of services as larger counties. Poverty is, we'll see some slides in a minute, poverty is associated with a ton of social health problems. And a lot of formulas, a lot of states such as Missouri and Utah, and I think even Wisconsin, Massachusetts, a lot of states, not in addition to looking at population, they'll look at poverty and they'll say, oh, okay, there's more poor people here, so we have to give them a little bit more money. And we'll see in a few slides that a lot of problems track with poverty. Local funding might be one of the more controversial ones, and I know we've already had several questions from our committee with regard to this. In funding formulas, local funding is, in funding formulas, state funds are generally used as a kind of an incentive, a minor incentive to local areas to quote-unquote tax themselves. So in other words, if you tax yourselves a little bit more than average, we'll give you a little bit more than average. It's not used as a big reward, but it's used as a little bit of a reward. Consolidation is, consolidation is another possible hot button. However, there's a few different, here's the nice thing about a larger system. And when I talk about consolidation, I'm talking about several counties, several health districts combining into one big district. The reasons for that, you've got a lot of economies of scale. There's a lot of different types of professionals, as you've heard, a lot of different types of professionals that have to work in these offices. A lot of offices can't afford a full-time person. Several counties together with a big enough population might be able to. So you've got the economies of scale. You've also got the ability to build a broader network of alternative providers. For example, the classic example is in cities. In cities, you've got a lot of other charitable organizations, hospitals with free clinics and things like that, things that you might be harder to find with piecemeal applications. One, I think, was it Representative Stevens or Rinder had a question about this, about effectiveness, getting back to effectiveness again. The fact that, did this make it through? Yes. Larger populations are associated with better performance. So the larger, in terms of population, the larger the health district, the county, whatever it is, the health district, the larger the health district, the better performing. And when they look at better performing, they tend to be looking at things like broad range of, offering the full range of services, or all those 10 essential services, that kind of stuff. Some formulas, this mostly is actually in one of the western states. Some formulas use land area, mostly in an acknowledgement of the fact that for the poor inspections people, if you're living in a state like, I think this was in Utah, or who used Utah, somewhere like Utah, recognition of the fact that, boy, it's really far between restaurants out here. The hold harmless just means, that's the clause, I don't know what you call it, that's the clause that says no county's funding can go down. And we'll see in a minute, I'm going to throw a slide up in a minute, it tends to be destructive, and I'll save my comments on that till I get to that slide. The last one is accreditation. Accreditation goes towards some of the standards that I think actually Greg will talk about, Greg Sheffield will talk about a little bit later as well. But accreditation just means, are we going to start looking at certain standards for our health districts? Standards in terms of staffing, standards in terms of, and when I say staffing, I mean the qualifications of the staffing. Standards in terms of orally basic things being done. A lot of different states are starting to do this kind of thing, accreditation. Only one state, to my knowledge, is actually tying money to it at this point in time, but a lot of other states are doing it. For example, I work with Missouri as well. Missouri has a very, it's almost a model accreditation program. A lot of other states have looked at it, and it's a pretty good accreditation program. It is currently voluntary. Not all of their health districts are doing it yet. Missouri talks about someday, put it this way, the health districts have been warned that, okay, it's voluntary now. Someday we're going to make it mandatory for receipt of funds. But it's a lot like what you'll be dealing with after we're all done here today and tomorrow. When you'll be dealing with it, it's a battle of political wills. as to whether or not they can actually start to enforce those accreditation rules. We've also heard some questions already about minimum staffing levels or standards for doing things. There's an awful lot of, there's 50 different standards in this country. Your staffing, one for every state. Your staffing levels might be higher than some states and lower than other states. But we get to a big problem here. How do I compare you to New York? How do I compare you to California? The range of services offered here might be broader than those offered in another state, or might be more narrow. So staffing comparisons are a little bit meaningless because you're not offering the same thing. If you, and one of the things that you will get, however, is by measuring better, and one of the outcomes of this is we're going to start, we measure a lot of stuff. There's a lot of other things that we could start measuring more. By measuring more, we'll get better measures of efficiency. And what'll happen is, and it's one of the classic problems. I can come here and I can tell you how it's done in another state. And every time I do that, I used to work with physician practices, for example, and I would tell them how it was done in other physician practices, and they would say, well, yes, but every physician practice is different, so every state's different as well. So me telling you how they did it, exactly did it in other states, you're not going to adopt that anyway. You've got a great learning center in the form of your own counties. As we look at different measures for different counties, and as we get more precise with those measurements, what you're going to do is you're going to find out, boy, some of the best practices are right here. And the nice thing about them being in Georgia is at least you know that it's moderately local. Then there is a whole host of other needs that you can look at. Low birth weight, mortality. And when I look at mortality, one of the most important mortality rates is early mortality. That is mortality before the age of 65. And I've run a lot of these numbers for all of your counties, incidentally. The low birth weights. Some other things you have: access to prenatal care, immunization rates, STDs, TBs, number of facilities needing inspections, things like that, restaurants, those things. Teen pregnancy rates, provider to population ratios. Now, not all of these things need, quote unquote, are directly public health's responsibility. For example, provider to population ratios, in other words, how many doctors are there per 1,000 or per 100,000 people in each county. That's not necessarily public health's responsibility to bring up the number of doctors, but it is, since, as we're all hearing, since they are the safety net, it does affect the need of people there, because if there's few doctors, then boy, the public health center is going to look a lot better because they're one of the only places around. Now, you could go back, we've got 3 slides of things that I've mentioned already. We could go back and we could try and fit all of those things into a formula and really make it pretty complex. But this slide tells you that there's a little bit of relief in that a lot of problems of society had the good manners to correlate to each other highly. This one shows poverty going this way. There's no easy way for me to get over there. Shows poverty along this way, more poverty going this way. And on the top, it goes gonorrhea, teen pregnancy, and early mortality, that is death before age 65. And you can see that the poorer you are, going towards the right, the poorer you are, the higher every one of those things goes. The upshot of this slide is that, although I've mentioned a lot of factors, a lot of them correlate, so that if you just tell us, for example, poverty is always a good one. That's one of the reasons why poverty is in a lot of formulas. Poverty really is associated with a lot of problems like this. If you looked at education, you'd also find a very similar tracking in terms of, well, it would be opposite, because greater education reduces all these problems. Quick overview. I told you I would tell you a little bit about what other states do. Missouri, what they did is Missouri came out of what you've got right now, counties are getting more or less what they've been getting for a while now. Missouri had that for a long time, and then a few years ago they got a little extra bonus from the legislator, and what they decided they were going to do is they were going to take that bonus and start building anything extra using a formula. And their formula uses population, where more people gets more money, poverty, where more poverty gets more money, local tax resources, where people who tax themselves more to pay for their own local public health get a little bit more from the state, and then a multi-county score, which is an incentive to consolidate. So in other words, if you two counties were separate, we would be giving you this much, but like 100 each. But when you get together, we'll give you 220 each. We give you a little bit more than you would have gotten separately. Utah has a very similar formula, but they incorporate land area as well. Utah also has a hold harmless. Missouri has a hold harmless as well. In fact, in those historical allocations that never change. The new monies are using the formula. The old monies aren't. Utah actually just revised things, but built in a hold harmless as well. And Wisconsin, the reason I mentioned Wisconsin is it's a little bit crazy, but I think it was it Representative Rinder who was talking about. What, pardon me? Reinders, excuse me, sorry. Was it you that mentioned the funding for as it relates to efficiency? Mm-hmm. Okay. Wisconsin took, and I'm a bit of an economist, so they took an economist's point of view. What Wisconsin did is they built this 5-factor formula, and for each of these 5 factors, service level is fairly easy. Are you a full service provider? Do you provide medium levels? Are you the what do they call it? The super Walmart or the super Target, the regular Target, or corner store levels of service that are provided by the counties. The population, target population, that goes to things like poverty, like things we've talked about, poverty, TB rates, stuff like that. They look at these risk factors like STD rates, education, stuff like that, and then they look at geographic factors like area and density, population density. For each one of these 5 factors, they have a group of 10 to 15 people, eggheads like me, people like who actually have to work for a living, get together and figure out what different measures would go into each one of these. So for each one of those 5 you see up here, there'd be like 5 to 15 different measures in that, going into that one score, in effect. So they have a fairly complex system of building up these scores. And for what it's worth, this team of experts, the public health professionals, the researchers, and so forth, they can, from year to year, change what goes into each one of these buckets. Getting the buckets is complex enough. And then they take it, and they only use this bucketing system to decide on a general price range. But then the state, and this is where the economist comes in, they take this price and they go to the health district and they say, okay, well, we're going to need to provide inspection services for this county. And we think, according to our massive formula, that this would be a good price. And they offer the price. And the county actually has the option of saying no, in which case the state has to go and find somebody else to do it for that price, which might be a neighboring county. Or the state might realize through simple negotiation that, oh boy, this was too low a price. So what Wisconsin has done in terms of efficiency is Wisconsin's letting the market decide, letting the free market decide who the most effective providers are by basically making it a negotiating process. However, you've heard how long it took me to talk about this process. It does get a little bit messy. So that's the one downside to letting simple economics do all the work for you. Georgia's original formula, we've already had a lot of people have talked about this. The one thing I wanted to say, and this goes back to the hold harmless, way over there's 2 highlighted cells which really show horribly because they're light yellow on light green or whatever like that. But long story short, because of the way the formula mechanics work, population is disproportionately rewarded under the original formula. Changes in population are disproportionately have a disproportionate impact. Now, and that goes, but the problem in Georgia is people move and tax bases move. So what you've done is you've built a system that actually effectively, the original system, the original formula was meant to acknowledge that more people should get more money and lower tax bases need a little extra help. That's how the original formula worked. By freezing it, or having a quote-unquote hold harmless, by freezing it, you've actually penalized the very things that whoever, whatever people came up with the formula, you actually penalize the very two things, because by my population increasing, I'm getting penalized because I'm getting the same money, but I've got to take care of more people, which you're hearing a lot of. And also my tax base. If I'm getting poorer, my allocation is based on when I was quote unquote richer, before the factory closed or something like that. So the bad thing about hold harmless, and one of the reasons I'm not a big fan of them, is they effectively penalize the very things that you tried to acknowledge as a legitimate need way back when. Lastly, we talked a lot about all those different needs. We had a laundry list of items. Ultimately, you're going to have to build some measures of need into your formula. Now, it'd be nice if the formula did encourage efficiency and quality to address, well, not just your concerns, because you can say it was here already, to address my own concerns, because I know a lot of people don't like to hear efficiency with healthcare, but I always tell people, look, if you can take care of one person cheaper, that means there's another person you can now take care of as well. Once we develop this list, and I've already started this, we can do some statistical analysis. We can look at the relationships between needs, between the actual quality, between the problems that are out there today, and the funding. We can look at the relationships between all of these things, and we can use that analysis, in effect, to inform the next steps, to inform what the formula, not just the mechanics of what would a new formula do, how would it impact people, but we can also try and make sure that this new formula addresses these needs and will actually work to improve the health of all Georgians. Now, in terms of who's going to do that, you've got people like me, you've got the experts here in the room, and ultimately, a lot of it's going to come down to the legislators as well, because while we might have a lot of different areas of expertise here, you are the experts in terms of what will get through the legislature. And that's where we as a group will need your input to help guide our next steps to figure out what we should do with the formula. Thank you.
Thank you. And we will break and we'll ask our questions at lunch. Thank you. We're back at 12:30.
From the folk from DHR, it's harder and harder now for us to track grant and aid funding because it no longer shows up in the budget. So that's a hard one to come down and talk to you about specifics at the Capitol, because we can't really get our finger on how much money we're talking about. I know you're on a very tight time frame. I wanted to read you a letter, if you'll permit me, from a county commissioner that I asked to be here today, and he could not attend due to many other things. Is that permissible that I read his comments? Okay. It's from Webster County, Dave Wills, who's the chairman down there. Webster County is down in the southwest area of the state. Ladies and gentlemen, thank you for the opportunity to submit written comments for your consideration as you deliberate upon ways to improve Georgia's public health services delivery systems. As the full-time chairman of Webster County Commission, a position in which I have served for 10 years, I represent one of the smallest, least populated counties in the state. According to the last census, our population was only 2,390 people. As you might imagine, we face many challenges of an economic nature because of our relative size and corresponding lack of opportunity and development. The consequences of those challenges spill over into the realm of local health care. Webster County's only medical provider is our local public health department, which is staffed by one registered nurse and an administrative clerk. There are no doctors or other medical care providers in our jurisdiction unless you count our EMS operation, upon which we rely heavily. The health department is our first and primary line of defense against public health threats, as well as the health care provider of choice for many of our citizens, especially those with very low incomes and limited access to transportation. Yet, despite its vital importance, Webster County's health department faces a constant struggle to secure the financial resources to remain open, to continue providing services. The single most important source of funding flows from the state to the health department through the Grant and Aid program. Without this funding, our local health department would almost certainly have to close, portending serious, even dire consequences for many of our citizens. My understanding is that your committee may consider altering the Grant and Aid formula, possibly redirecting funds to more populous communities. If the goal of such proposed change is equity in funding, those changes may seem important, but I respectfully suggest that equity and access to health care should also be of paramount importance. In this regard, I am requesting that you not approve any changes which would reduce funding to rural communities such as mine. At the very least, please set a base amount of funding sufficient to ensure that our health department remains open and viable, able to deliver critical services to our citizens. I wish that time permitted you to consider a detailed explanation of the benefits that accrue to my constituents as a result of the services rendered by our health department. I wish you had time to consider a detailed explanation of why my county government cannot possibly offset a loss of funding should the Grant and Aid funding formula be revised to shift funding away from rural counties. But I know that you do not have that much time. So suffice it to say that the economic challenges to which I alluded in my initial remarks exacerbate the challenges we face with respect to health care, and that our local health department is an indispensable component of our well-being. In conclusion, as you deliberate potential changes to the formula scheme for local public health care, I implore you to remember that many citizens of small rural counties rely exclusively or nearly so upon public health care facilities for delivery of life-sustaining services. With that in mind, please preserve and even strengthen the funding of public health in rural Georgia, including Webster County. When you do, I and my constituents will be most appreciative. Sincerely, Dave Wills, Chairman, Webster County Board of Commissioners.
Thank you.
And I do have copies of his comment.
Yeah, we'd love to see that. And John Graham? John's a Warren County Commissioner and a Board of Health member.
Thank you all very much. Just wanted to kind of give you a little overview of another small rural county. A couple of years ago, we had 5 people working in our health department, and currently, as today, we're down to 3. Originally, we had the director, 2 nursing positions, a billing clerk, and a WIC clerk, with a part-time environmentalist. Now, due to cuts and things that we continue to see, we're down to the director, 1 nurse, and a billing clerk. We've lost a nurse position and a WIC position. Continuing with environmentalist 2 days a week. Some of the things we're seeing and problems we're having in this area is prolonged time to get family planning, health checks, other things. It's taken months to be able to get an appointment to see those things. And a small rural county as we are, with a poverty level of 20% from information from the last census, if you look at their data. And it goes on to say that 22% of our people are ladies are having late to no prenatal care, 13% of low birth weight, and 9% of premature births. And as we prolong their care, that starts to give us more trouble. Another issue that we get into is that I want y'all to look at from a state level is poverty is very important to the health departments. You're going to see more people that's in the poverty level needing to receive care, and that's probably where they're going to be. They're not going to be able to afford other means as in other areas. And I wanted to compare my neighbor next door to me, McDuffie County. Their poverty level is 17%. But one of the things when it gets into how much can the counties put in, and we're all in my region, as I looked at the 13 areas in the East Central region, we all put more than what the required match is at this point. But even though poverty is one issue, but you got to look at what the counties are able to do based on tax base. For my tax base, one meal only brings in $163,000. If you go next door, one meal brings in $465,000. 1 cent of sales tax brings in $480,000 to Warren County, where it brings in $3 million to my neighbor in McDuffie County. So you might look at what everybody's putting in to the, as their share, but you got to look at what they're able to do and what the different economies are for them. Just 10 miles apart, that's the difference we see. But if you look just at poverty, it looks like we're both having a lot of major problems, but they have a better tax base that they're able to generate from. So I just think that's something that ought to be looked at as we move forward with the areas of trying to do funding. Another part that we need to look at also is when you look at that dollar amount that we're putting in, you're not going to see a dollar amount for insurance on the building maintenance, building and grounds, all those things that we also pick up. That's another part of our budget. You will not see it in the health department because it's not what it's put in the direct allocations that you'll see on all your sheets. But we do spend a lot of time with man hours on those issues also. That's also costing us to keep the building, the maintenance to the building, so we can continue to providing services there. But that's just some of the things I wanted to try to touch on real quick, and I know y'all are short on time, but is to just, I know y'all think everybody's just, everybody wants more money. Every employee I got wants more money. I see that every year and deal with the budgets. Basically, what we want y'all to do is look at it real hard, not to, as federal government drops mandates on the state, y'all know how hard it is, and if it's dropped on down to the next level, it's just as tough on us. But I think if we can look at what counties are able to do based on tax bases and what the state's able to do to assist and everybody putting their piece into the pie, I think it'll go a long way to help us all out. So, any questions that y'all might have?
Thank you so much for coming today. I appreciate you.
Thank you.
Okay, now David Martin will go over the history of the grant.
You get me again. Good afternoon. Okay. Whoops. Went too far. You get through all these slides to where I'm supposed to be. Okay, one more. Okay, first I'm just going to talk about the existing formula and what we've been able to find out about it. You have to understand, there aren't a whole lot of people left working in state government who remember what was going on back in 1967 or 1970. I started in 1975. I didn't start working in public health until 3.5 years ago. But the formula, from what we have gathered, was created back in 1967, and it was only used through 1970. At some point before the 1971 allocation was done, something changed. No one remembers why, and we quit using the formula to allocate grant and aid funds. Basically, with a few exceptions, since that point in time, if a county was receiving 1% of the allocation then, they're still getting 1% of the overall allocation today. Okay? Any increases or decreases have been made in whatever proportion was in place back in 1970. That includes pay raises, that includes any additional monies that were given for any reason with no limits on them. The reductions that took place in 03, 04, and 05 were all proportionally allocated to all 159 counties in the state. Now, the exception to that is, and again, no one remembers why, there was a small per capita change made in 1978. I don't know why it took so long, based on population changes from the 1970 census. And once again, in 1983, changes, it was like 1.4% for certain counties, were made based on changes in the 1980 census. But nothing since then that we've been able to find.
You said certain counties, so not all counties?
We don't know. I suspect it was just to certain counties that had grown in population. Regardless of what it was not enough, it wasn't anywhere close enough to bring those counties back in line with what applying the formula may have suggested that they should be getting at that point in time. Okay. 2006. It's interesting that Webster County was mentioned because the lowest county allocation to any county in the state is Webster County. They get $66,000 a year in regular grant Nade. There's 68 counties that get less than $150,000. Why is that number important? That's what our administrators tell us that it costs to operate a minimal health department. A nurse, a clerk, and a half-time environmentalist. So there's 68 counties in the state that are receiving an allocation that is less than what our administrators think it takes to operate a minimum level health department from the state. And 9 counties are getting more than $1 million each.
Yeah, but we have a question.
Would you tell us again what you consider to be the minimum amount to operate
Our administrators are telling us that to operate a minimal health department, which is a nurse, a clerk, and a half-time environmentalist, costs $150,000 a year for that health department. Okay?
Well, okay.
We have no scientific basis for that other than their
how
experience and opinion.
Yeah, question.
How does Webster County do it with 66?
They don't have all 3 of those. All they have is a nurse and a clerk. They do not have an environmentalist. They rely on the district health office to provide any environmental health services that they require.
Question.
I got to drop this. So the part-time environmentalist is 44. Is hell of a math. $94,000.
$94.
Difference between 66 and 150.
Webster County is also one of those counties that, although it might be poor, is putting in about 3 times as much as we currently say the required local match is. So even though it's a poor county, they are supporting the health department.
How much are they putting in? There's 2,000 residents.
I'd have to look it up specifically, but I know they're one of the ones putting in more than what they're required to do. Several of our poor counties are putting in 3 times as much.
Get you up to 150,000.
Okay? So that's where we are. We have not been sitting still in public health. We've been trying. We recognize that the formula does not necessarily allocate funds in the best way, and we've been trying to come up with different alternatives to change how things have been for 30 years. The first was to apply the old formula. Now, before I get into that, from the 1970 to the 2000 census, the population of the state of Georgia changed by 78%. Bottom line, if we use the old formula, counties that grew less than 78% in that 30-year time span lose money. Counties that grew more than 78% in that time span gain money. When we apply the old formula, 81 of the 159 counties in Georgia lose funding. If we simply took the existing dollars, the old formula, and reused it, over half the counties in Georgia lose money. They lose anywhere from 70% of what they're receiving now to gaining 200% above what they're receiving now. The lowest county allocation goes from $66,000 down to $22,000. There'd be 5 counties in the state that get less than $30,000 in grant and aid. 8 counties get less than $50,000. We add 1 more county to the ones receiving less than $150,000, and 12 counties now get greater than $1 million. That's if we simply use the old formula. we came up with different scenarios for a new formula. One of the examples that I'll share with you is we came up with a formula that used population as a factor. It used the poverty population in a county as a factor. It used the health status as a factor, and we were defining health status as a combination of teenage pregnancy, infant mortality, and years of potential life lost under the age of 75. Our statistical folks played with that and came up with a number that allowed us to compare counties. And health access, which we used data for emergency room admissions for diseases that can be treated if you have a primary care physician and avoid hospitalization, like diabetes or asthma, things like that. We use that as a marker for health access. We combined those four factors and played around using different weights among those four. If you assign population 1/4 of the weight of in the whole formula, 97 counties out of the 159 lose money under that proposed formula. Anywhere from 70%. The gain's not as big this time. The largest county gains 86%. If you reduce population as a factor to as low as 15%, 93 counties still lose money. We tried doing what you heard Dr. Burnett say we shouldn't do, applying hold harmless caveats to the formula. We ran the numbers saying that any county getting less than $100,000 will not see their funding reduced, and no county that currently gets above $100,000 will see their grant go below $100,000. Even in that scenario, 78 counties lose money. 22 counties get exactly the same thing they're getting today, and the range of loss is anywhere, or gain is anywhere from 51 to 84%. So the bottom line is, you've heard about the demands on services, the increase in population, the impact of inflation. We haven't been able to come up with a formula, regardless of what it is, that will get around those issues so that some parts of the state lose as other parts of the state gain. And it is not always the smallest, poorest counties that lose funding under these formulas. It is some of our larger metropolitan counties also are impacted. Okay? The last thing I'd like to talk about is there was also in 1967, it's been alluded to, a required formula for county county match. Basically, it said that you take the county per capita tax digest, you divide it by the state per capita tax digest, and you multiply it by the grant and aid allotment. Now, what that tells me is that if a county was exactly the same as a state as a whole, that number would wind up being 1, and the county would be expected to put in dollar for dollar to the local health department just as much money as the state's putting in. Okay. That formula is not in statute. We suspect it was something that someone came up with and the Department of Public Health Board at that time approved. But it hasn't been used since May of 1973. The local match amount was frozen May 1973 at its current level. And when I say frozen, I mean literally, if the dollar amount the county was required to put in 1973 was $9,000, today it is still $9,000. It has not changed. It hasn't gone up or down proportionally or anything else. The total right now is a little over $12 million. And if you use the current population, that means some counties are putting in as $11 per resident, 11 cents per resident into public health, while other counties put over $4 per resident into public health. Just for the heck of it, we took the match formula and applied it using today's figures, the FY 2000 Census and Tax Digest. If we use the match formula today, the total state required match amount would go to $58 million for local governments. That would range from $1.64 per resident to over $32 a resident. 118 counties would have to increase their contribution in local public health in order to meet that match requirement. Now, unless you think counties are only putting in $12 million, the required local match right now is $12 million. County government in Georgia actually gave public health departments or invested in public health departments over $50 million last year. They were not required to, but they did. And that does not include the things like the commissioner was talking about a minute ago. In those counties that were required to furnish the building and the facilities, that does not include those costs of providing that building or maintaining that facility that the county governments are responsible for. That's just actual cash tax dollars that flow from county government to the Board of Health. And other than that, I'll try to answer any questions.
Any questions? I have a question. I know we've talked about, so you've run the numbers to know, obviously, what counties would benefit and who would be harmed and who would be benefited. So, how much money are we talking so that no one, you kind of, the hold harmless, and no one loses, but it brings those counties that haven't, the formula hasn't changed to reflect changes in population, to bring them up to some minimal standard?
I can't answer it the way you're asking it.
Okay.
The only thing I can give you a price tag on is we have run the numbers in a different way.
Okay.
There seemed to be at one time a lot of concern about per capita grant and aid allocation.
Mm-hmm.
And if you look at the average, if you take the current amount we allocate divided by the current population,
Mm-hmm.
the per capita is a little over $6 per person, $6 and some cents per person in Georgia. If we were to take every county that's currently getting less than $6 and whatever those cents are per person and say we want to bring every county up to at least that per capita level, that would take approximately $13 million.
Okay. All right. Representative Chanel.
Thank you, Madam Chairman. What is it? You said 150,000 was what you consider.
That's what we've been told.
That's what?
That's what we've been told is the minimum amount to operate a local health department with a nurse, a clerk, a half-time environmentalist, and all the travel and supply and utility and other costs that go along with it.
That's a number that you agree with. Is that right? What is, my question is, what is the lowest current amount of grant and aid that any?
The lowest current amount that we give to anyone is Webster County, $66,000.
Well, that's the lowest. Do we have, Madam Chairman, available by county? What everybody? I'm sure we do, but what they're getting now?
Have we received that? Per capita breakdown.
Well, I mean in total. I think
the actual amounts in one of those files that I sent on Friday by county.
I know a lot of files Friday, as you can tell.
Yeah.
It may be in front of you. I don't know. Did you? Okay. Does it have the county total in there?
Yes, they do.
Yeah. Yes. I think you received it. We did receive it our first meeting. This is in there. Any other questions? Thank you. And now we hear from Greg Sheffield.
Good afternoon. I'm from Gainesville, in the same position Ty is from Cobb County. But I'm not here to talk about where we are now. I'm here to talk about what we're doing and what our future plans are. I've been employed in public health for the last 15 years, so it makes me seem old compared to what everybody else does, because you didn't say how long you'd been here. But during that time, we've made great strides in public health as to try to deal with our financial needs and the changing impact of our state demographics. Just over a year ago, we formed the FACT team, the Public Health Alignment for Change team, and where we involved our state partners in a summit to develop our focus on our health status in Georgia. we did that so in order we could work effectively within the broader scope of the health system and the health department system, we strengthened our organization capacity. We divided this up into 4 teams, and I'm the co-chair of the financial team. And in the financial team, let's see if I can make this work now. Down arrow. There we go. We've divided up into 3 goals, and it's fiscal accountability. Our first goal is to improve our ability to demonstrate the value of our work in dollars and cents. Our second goal is allocated funding, appropriately allocated funding. This is the work that we're doing in funding allocations that we know that take the important foundational steps to develop the funding structure that is equitable. We're committed to make these improvements as well as to try to achieve our goal. Our last goal is to align those resources with the public health needs and to remove any silos or any type silo funding to the public health system and find ways to be flexible in meeting the health department's needs and the health needs of our communities. As you can see, our team's taken a great deal of work ahead of us, and we're committed to make these necessary improvements for a safer and a healthier Georgia. Okay. Do you have any questions?
Any questions? Okay.
Okay. Thank you all.
Thank you. I think is that it? Okay. That's the conclusion of our agenda. Any questions or comments from Representative Stevens? You're number 23? Okay.
Dr. Burnett, I'm looking at your funding formula here, and I'd like to go just a little bit deeper if I can. And the very last sheet on your funding formula, just before we get to the graphs, which point to, in my mind, that the needs are where the poorest are. Have you got any? The last thing you've got here, needs are highly correlated and related to income.
Mm-hmm.
Can you expound on that some more? And in your personal opinion, where we need to weight our dollars?
Well, I'm trying to find a slide so everyone can see what the slide you're talking about. There it is. It just shows that poverty. There's a lot of things that track with poverty, gonorrhea, teen pregnancy, and so forth. All of the purpose of this slide was to say, there's a laundry list of things we can look at. There's all kinds of public health indicators that we can consider, and they're all important, STD rates, TB, and so forth. However, they've all had we've got the fortune that they all track pretty well according to certain key indicators like poverty. So by putting poverty, if we were to add poverty to the formula, by putting poverty in the formula, it's a lot like saying we want to put gonorrhea rates, teen pregnancy rates, all these other public health problems. It's a lot like saying we want to address these in the formula just by putting the one poverty thing in. Luckily, poverty is easy to measure, routinely measured, and it can take the place of a dozen other variables and do a fairly good job of saying, well, if you're really worried about TB and STDs and these other problems, just by saying part of the money that we're going to, part of this pie goes according to poverty, to accomplish that.
Okay. One follow-up.
Sure.
If you had I'll put you on the spot. If you had an opportunity to give us a formula, what would you do?
I would work with these fine people in a room, and as David said, we've already kind of played with these numbers. And I'll tell you, if we do, poverty would be in the formula. Population would be in the formula. Would have to, and this is where I ended my regular talk, kind of throwing it back to you a little bit. And at lunchtime, I've got some more input. But some of the other things that we need to consider are things like the hold harmless, and the hold harmless is more of a political reality thing. Even if we come up with the best formula in the world, and again, the intention of the formula is looking at the public health of the entire state, come up with the best formula. Those counties that are going to, there's going to be some winners and losers. The counties that are going to lose, they're not going to be happy. So, for political expedience, I understand that we're going to need some kind of hold harmless. And then there's some other things that I would put in the formula as well. We talked about, David was talking about the No, the health status, because poverty's been on that. The tax, the contribution, local contributions. Local contributions, and this is something we were talking about at lunch, it's handled differently in other states, but I'm kind of a big fan of, and actually I've never seen it done quite this way in other states, but it's kind of something I would like to see, which is a financial pain index. Not just looking at how much the locals put into their own public health, but what is that as a proportion of their tax base? So in other words, if they're, is it really hurting them to put in, let's say, whatever, $5? And if it's really hurting them, then maybe the state can say, you know what, you really are trying very hard. You're taxing yourselves, relatively speaking, heavier to do this. So maybe the state can reward that, saying, okay, in terms of the financial pain, maybe some reward of that. But then, I'll be honest, then we turn it back to you because we can kind of come up and say, here's different slices. And let's say there's 4 basic slices. Here's these big slices. You can decide on the relative share. I mean, we can propose something, but then this is where it goes back to you. Politically, what's going to be easiest for you to do? We can say, how much % we think should go to population. But whatever we gave you, it would have, we're going to give you the projections. We're going to say, this is how it would pan out if you did a zero-sum game, which is to say there's going to be winners and losers. We can present that to you, but then just by changing the size of each slice, this big slice, but the population slice, poverty slice, by changing the size of that, you'll actually change the distributions. You'll change the winners and losers. So, I mean, we can recommend a formula, like I said. We can recommend a formula and would give you, some of the results, but then recognizing that you're going to get to tweak the sizes of the slices anyway.
Thank you, Madam Chairman. In terms of coming up with a formula, as we discussed to some degree at lunch, we probably need several different things to look at. But would you not agree that, and it was pointed out by the chairman from Warren County and also the chairman from Webster County, that some base level of funding is going to have to be the starting point. Now, whether or not that base level is $150,000, obviously that's another discussion. But the practical matter is you can't spend percentages and you can't spend per capita. I mean, if you're going to have in these smaller counties, if part of the mission of public health is to provide public health departments in 159 counties, then you're going to have to start at some point in time to be sure that you have somebody in the health department, and whether that's 2 people or 1 or 3 or whatever it is. But wouldn't you agree that that's where you got to start at some base level of funding, and then talk about the formula?
Yes, I would agree. The number might be different from someone like me, more of a finance and business person. So for me, 40 regular hours a week or something like that might not be required for a county. And I'm not saying that people in the smaller counties don't have needs. I'm just saying from an efficiency and effectiveness point of view.
I'm not suggesting a number, but I mean, I'm talking in terms of concept.
Yeah.
Enough money for a, taller county is a neighboring county of mine. They got less than 2,000 people in. I don't represent the county right now, but that's an example, and certainly Webster County and on and on. I mean, throughout the state.
Yeah, and well, it's kind of addressed in 2 ways. Is there a minimum? Yeah. The trick is, I don't know that a formula would be the right place for a minimum, because then with a minimum, we have to keep it up to date and adjust it for inflation and something like that.
I was just talking about a baseline, a base level of keeping the door open, and then do the formula, is what I'm suggesting.
I'll be honest, it's addressed in 2 ways, even if we just look at this. The hold harmless addresses it by saying, okay, we recognize for political expediency that we can't start yanking money right away. And the other thing, this is one of the quote-unquote fortunate things, a lot of the counties that you talked about, a lot of those smaller counties, and I think David alluded to it, in terms of that pain index that I was talking about, that financial pain index, a lot of the smaller counties are doing quote-unquote more than their share. So they recognize that they have public health problems and public access problems, and they're trying to spend beyond that required match.
Representative Reinders?
Thank you, Madam Chair. I appreciate everybody showing up today and really all what you do for the public health and certainly the information that you provided for lunch. I would like to however, just bring the point that while I'm sensitive to our health care providers, I do think some people took the opportunity to talk about really how they're not getting by on what they're given already. I do view that this committee, Madam Chair, was charged with looking at the appropriateness or the fairness of the current formula, and not as a committee that's designed to look at necessarily at this time of an increase in any type of appropriations for the various districts. Now, certainly that can always happen, but I am of the opinion that we wanted to look at the fairness of the current formula, and I'm hopeful that that's the kind of information that we would get.
Thank you. Any other questions or comments? I thank you. Definitely enjoyed lunch today with Dr. Burnett. Thank you, Renders. But we are continuing. This is a major subject. I don't know that we'll be able to come up with a solution. I'm sure we won't after our meeting tomorrow, but we will continue to work on it. We are definitely, like as Representative Reinders said, our goal is to find a formula that's fair for Georgia to ensure that adequate health care is available. Well, for funding for public health departments, I think we saw definitely from David Martin that the current funding formula has been in place for years and is antiquated and is not working, and we have got to address. And there will be. I guess our goal is just to come up with a formula that definitely works for all of Georgia's citizens to ensure that there's all of the poor in Georgia are served. So I appreciate each of you coming today. I know some of you have commitments tomorrow. Definitely is not a reflection of your interest in this, but we definitely appreciate your diligence, and we will see you tomorrow. Will be our final committee meeting, and we'll meet from 10 till 1 tomorrow. Thank you.